Good afternoon and welcome to ICE Webinars, a cool place for hot topics. Today we are joined by Melody Mulaik, President of Revenue Cycle Coding Strategies, a national consulting firm that serves healthcare systems, physician practices, billing companies and other industry stakeholders. Melody is a frequent speaker and author for nationally recognized professional organizations and publications, and her areas of expertise include coding and compliance, management engineering, and operations improvement, and she is nationally recognized for her extensive compliance expertise. Now, just a quick reminder to save the date for our 10th anniversary ICE 2024, which will be held at the Hyatt Regency in Irvine, California, from February the 18th to the 20th. The Imaging Conference and Expo is the only conference dedicated to imaging directors, radiology administrators, and imaging engineers. ICE offers valuable CE credits from the ASRT and ACI and is a unique community of key decision makers and influential imaging professionals. For more details, please visit attendice.com. Today's webinar is eligible for one AART Category A CE credit by the HRA. You can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE credit, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. We'll wrap up today's presentation with a live Q&A, so please submit your questions anytime using the questions feature on the webinar dashboard. Okay, let's kick off today's webinar by giving away one of our ICE gym bags to the attendee that can tell me the answer to the following trivia question. August is National Eye Exam Month. What is the most common eye colour? Answer now using the questions feature on your dashboard, and I'll reveal the answer at the end of the webinar. As I mentioned earlier, Melody is our presenter today, and she will be discussing Don't Let Revenue Opportunities Slip Through Your Fingers. Melody, you may begin whenever you're ready.
Thank you so much. Thank you, everybody, for attending the session today. We are going to cover a lot of different content in our time together. And as she mentioned, we will be having some Q&A at the end. Just as an FYI, I can't see your questions as they go along. So if you post anything and think, why isn't she answering it? Because I don't have visibility to that. So I'm going to be focused just on the presentation. But please do put those questions in there, and we will go over those at the end. And if we run out of time, or you have a question that I'm not able to answer during the session, I am happy to follow up with you as that as well. So you do see that you have the ability to download the presentation as well as some additional ICE information. With that, got your disclaimers. We're covering stuff as we know it today. Always verify websites, etc. So we're talking about revenue, and don't let revenue slip through your fingers. And so this may be a little bit different approach to that than maybe what you've heard in some other sessions. So when I think about walking into an organization focused specifically on imaging, and we say, okay, if an organization thinks it's potentially losing money, and when I'm talking about money, we're talking about revenue related to how we do billing and coding and all those types of things, there's going to be several different things that we can look at. So it's not always as straightforward as, well, did we code everything correctly? That's one component. But it really, we have to look at it across the whole continuum of the revenue cycle and of our processes. So we're going to look at this not only from an identification standpoint, but also where is it that we need to look and what are the things that we can potentially do about it. So we're going to start with front-end operations. We are going to talk a little bit about orders, point of service collections, and those areas where if we don't have good processes in place, what can we do about it? Again, we will talk about coding, documentation, and billing. Where are there potentially some opportunities today? Focusing a little bit more on the IRP, some of the E&M coding that's out there, but there may be other areas as well. Then talk about denials. You know, maybe we've done everything correctly, we've billed it all, but yet we're still not getting paid on the back end. What does that matter to you from an operations standpoint? Briefly on credentialing, and then potentially some other issues. So as we go through the session today, really my goal is for you to walk away with a to-do list for yourself, because the answer is different for every organization. What are the things that you can go back and look at, maybe to identify some areas of opportunity within your organization? I would say that every organization has some opportunities, right? I mean, no place, processes are never going to be perfect. There's always going to be challenges, whether it's with our systems or with our payers or with our ordering providers. With that, it's how we approach it. The other thing I would say is sometimes we may be discussing things that you may say, well, that's really outside of my control. I don't control that. I'm not responsible for it. You know, I'm kind of stuck. How can I make a difference? I would challenge you to say, if we collect the right data and present it to the people where it is their responsibility, we want to do that in order to be able to make changes in the process. So let's approach it from that standpoint together, again, with identifying where might there be some opportunities. So to start off, I want to mention, you know, one of the things that we also want to do is really involve our radiologist in the process. So whether you're on the hospital side and you're a hospital administrator, and maybe they're even whether they're contracted with your organization, or you're coming directly from a practice and you actually are responsible for the radiologist, regardless, getting your radiologist involved in what you're looking at becomes really important. And so it may not be every radiologist in the practice, and generally it's not, but even finding, you know, a 1, 2, 3 champions within the practice to assist you makes a big difference. That makes a big difference for the radiologists themselves and their satisfaction, but also for you and your staff, showing the engagement of the radiologist with it. It really helps reduce turnover, and I would argue that it does increase revenue to the organization. Again, whether you're physician side or facility side, having that radiologist engagement and working in partnership from a business standpoint, from an operations standpoint, definitely can make a difference. And sometimes our radiologists can go and get the attention of people that maybe we don't have the ability to do, depending on what the roles and responsibilities are as part of that process. So let's start that journey of looking at where is there potential opportunity. So if we start at the front end, so front end being before we ever provide services to the patient, before they've even come in the door, let's start with where are potential opportunities. So our big one, right, orders. So I always have to ask the question, whenever I'm with a group of people doing a presentation, I'll say, how many of you believe that ordering providers always order the right exam 100% of the time? And I will tell you, nobody ever raises their hand, right? Because we know that we don't always get correct orders 100% of the time. Well, okay, if not, why not? We can't just say, well, because they don't know what to order. I mean, there's a lot of general things that we could say, but what we want to do is get into the specifics and think about, okay, if I have an issue, why do we have this issue and what can we do about it? Because again, you know, you really have to go back to the adage, people do not show up, whether it's a doctor or a staff member, to work on a daily basis to make mistakes, right? People are really doing what they think is the right thing. We give them the benefit of the doubt, right? It becomes back to process. So I would say the majority of the issues that we have are process problems more than people problems. Not that there can't be people problems, but the majority of the time it's a process problem. So if I'm having an issue with orders and I drill down a little bit more, I would say, let's talk about our 3 main areas of where we get our orders from. We have the emergency room, we have outpatient, we have inpatient. If I look at the emergency room piece with that, when I look at that piece of it, it's typically the problems that I generally see or how things are ordered. It's how the ER docs see the information. So I go back to what is it they see. Again, most ER docs are not aware that saying rule out DVT is not sufficient information. And you would say, well, of course they know that. Not necessarily, because their focus is not on the imaging side. So we could spend a whole hour talking about how to make that kind of change. But again, understanding why things happen, looking at order sets within the system, be it Epic, Cerner, et cetera, can make a big difference. Outpatient side, I would be so bold as to say we really should never have, and we should never see an outpatient for a scheduled outpatient procedure that we don't 100% know that it's the right exam and we know the clinical information. If we don't have that all the time, we have a breakdown in process. We never want to have the patient back with our technologist back in front of the equipment without going through those hoops, because if we miss the mark, we potentially are doing that study for free, and that's revenue, right? So that's one of the key pieces. And then inpatient is problematic sometimes depending on how the orders get entered. Nowadays, in our very electronic world, with our ordering providers typically doing it immediately as they're seeing the patient, hopefully we've seen some of that go down as opposed to being entered by, you know, kind of the clerks on the floor and things like that, but that's something to consider. So think about where your problem originates from. That's going to drive a different workflow depending on what the issue is specifically for that. So then we'll get into, so we got orders, and I'm going to come back to that a little bit more, but then let's talk about prior authorization. So prior authorization is where our commercial payers, you know, the Aetnas, the Cignas, United, the list goes on, require that we get approval in advance for doing a particular studies. So technically, it is the responsibility of the ordering provider to get that prior authorization, but for a lot of organizations, if you're all part of one big family, one big umbrella company, shared medical record, et cetera, a lot of times it is going to be done by your entity with that. But do we have issues with getting prior authorization? And the short answer is going to be probably yes, because we definitely see a lot of denials around prior authorization. So that has to be built into the process. We think about MRIs in particular, and even CTs and nuke med. Where does that come into play? Because if we circumvent that process in any form or fashion, we potentially are doing those studies for free. So we don't want to do studies for free, right? Not really fair. So let's look at how these things happen. So back to orders for a second, because orders and prior auth definitely go hand in hand, because if a physician orders a service and we don't prior auth the right exam, we also are potentially putting revenue in jeopardy from that standpoint. So again, we want to avoid generalities. We don't get good orders. This physician practice doesn't provide good information. Let's dive into it a little bit more. Why is the order incomplete? Is it an IT problem or is it a people problem? When I say a people problem, if we want to flip that, we could say, is it an educational opportunity, right? With that. So what's the cause of it? How can it be fixed? And I will tell you, it can always be fixed, but if you perceive that it can't, right? So maybe it's a system problem and you're saying, I've run up against a wall, we can't change it. How can we accommodate the process? We don't want to have to do workarounds, but sometimes we have to. What is it we have to do? That doesn't mean we're breaking any rules. That doesn't mean we're not doing things compliantly, but are there ways that we can work with certain providers to enable them to do a better job of ordering for certain things related to it? Or we know sometimes change is slow. So you may have identified something with an Epic that needs changing, but you know it's going to take 6 to 9 months to get it done. What can we do in the meantime? And what are we doing to educate the staff to make sure that those particular things are going to get done? So, you know, again, we can't say, well, it's impossible to fix. I promise you there's organizations who found ways to fix things. It just sometimes takes time, takes a little patience, but we got to work through it. So when the order's not complete, so we got that scenario, we can talk about that, right, a little bit in theory if we know we need to fix those things. But what do I do about today, Melody? How do I handle if I get a bad order or it's not complete? Well, you know, you got to look at, what are you going to do? Are you going to do whatever's ordered no matter what? I would say probably not, because we know we don't want to irradiate patients if we know it's not the right exam. With that, how do we verify? Do we have a process for the technologist to call the ordering provider's office? Is there some sort of mechanism in place for that? And, you know, are you really okay with it? I mean, what's your culture? Sometimes I see organizations have a little bit of fear because they're worried, well, if we push back on this provider, they're just going to leave us and they're going to send their patients someplace else. Okay, so a couple questions or responses I have for that. One is, if you're doing a lot of their stuff for free anyway, are you really hurting yourself? Have to bring that up. Secondly is, if you're providing the quality of care and the radiologists are providing the quality of interpretations that ordering provider wants, and your physicians have the reputation and your facility does, do you really think they're going to leave because you're asking them to step up to a higher standard? So it's a little bit, you got to think about it from that perspective as a whole, because if you are providing a high standard of care and a physician is really going to leave you because you asked them to do a little bit more, again, I just have to raise the comments or things for consideration. So again, when you look at identifying where do we focus our energies around orders, I don't try to do everything all at one time. Focus with it. You know, I kind of say, do your homework of where do you want to focus? Is it CTs? Is it a specific practice? Is it a specific modality? Let's get as granular as we can and figure out where our biggest problems are. Then we can go back and make changes there, and that will make a big impact. Not that anybody likes doing anything from a manual standpoint, but if you have your technologist track the number of times they have bad orders or incomplete orders by practice, and gather that data. Let's say we gather it for 2 months, or not 2 months, 2 weeks, or even a month. That's going to give you a lot of data where you need to go focus your attention with it. So I do recommend some very specific pieces with it. So when I look at that analysis around those order pieces of it, again, can we figure out how it happened? And it may not be what you think. It may not be, well, clearly somebody on the front end is just letting this through. Again, what's your process with it? Because finding errors is easy. We can all point fingers and find errors and identify the problems, but how can we get to root cause analysis? And if that's an area, again, that's outside of your control, that may be where you need to partner with somebody from the rev cycle or on the front end, so that they go into that with an open mind and approach it with you jointly of how to fix that particular problem. So orders is definitely an opportunity. If we're missing orders are incorrect, we're not getting prior authorization, then that is potentially a source of where revenue might be. Secondly, on the front end would be what's called point of service patient collection. So think about, you yourself need to have an MRI scan, and they contact your insurance company and they look at what your benefits are, and they determine based on where you are related to your deductible or what your plan says. Let's say you owe $600 with that. Ideally, and best practice is that you would know that. You would know that you owe $600. You would know that from talking to somebody at the location prior to ever showing up with that. And when you show up to get your scan done, they're going to say, welcome, Melody, for your MRI scan. As you're aware, your payment due to us today is $600. How would you like to take care of that? Now, some of them will even ask you ahead of time, but let's say they're doing it right there. With it, I know my responsibility when I walk in the door. For that piece of it. So where can that go wrong? There's a lot of ways that could go wrong that could have a very serious financial impact of revenue to the organization. One, is authorizations taking too long, right? With that, and is a patient being offered the opportunity to become self-pay because they don't want to wait on the authorization? That is not an ideal, and I would argue not a best practice, and authorization should not take that long. Most private payers now have portals where you can get prior auth pretty quick. And I've even seen, even for MRs, some of the very large insurance payers are doing what they almost call snap authorizations, where they put the data into a portal and it gives an immediate response for that. So that the old days of having to keep calling and it take 2 to 3 weeks, I would argue if you have the right technology, it doesn't take that amount of time anymore. So let's say on a worst case, it's 3 to 5 days, but we know we're scheduling 2 weeks out for MRs. We could still get that patient on the schedule, still do a prior authorization. But let's say that your organization does allow patients to become self-pay with that. Managing that process is a big deal, because there's a lot of places that can go wrong, and patient gets put as self-pay and then back to we build the insurance, and then all of a sudden you get into all sorts of issues again that I won't go down that pathway, but that can create some challenges. The other thing is if patients aren't receiving accurate estimates of their services. We're talking big ticket dollar items. Patients are coming in to get MRIs and get CTs and other things where potentially they may owe hundreds of dollars, maybe potentially above that. With it, are they getting accurate estimates so that there's confidence in what's being done? Regardless of your clinical quality, and I think you guys know this, both from a patient standpoint and from somebody working in the industry, regardless of the quality of what you provide, if a patient's bill gets messed up, they're not going to be happy. And they're going to talk more about that than they're going to talk about what a phenomenal job you did doing their MRI scan, right? So this patient's, we call it the patient financial experience, I would argue is equally important, not more important than clinical, clearly not, but it is extremely important that we give patients the right bills with the right information on there, because again, that's a reason that they potentially wouldn't come back to the organization. And then the other things, is do we have consistency in the staff? I mean, some of you come from imaging center side, which is a little bit easier to control with the front end. But if you're in a hospital system and there's a whole lot of intake pieces into the system, are they consistent? I mean, this is a stressful job. I mean, you think about interacting with patients, they're already stressed out, they're having to come get imaging done, and they push back on that person on the front end that says, hello, Melody, you owe $600. If I push back on that person, are they gonna stand strong and say, I'm sorry, that's our policy, we informed you of that, in front of it, whatever, did we train them on customer service? Or are they just gonna say, okay, no problem? Again, here's another place where revenue potentially can slip by with it. So again, recognizing some of you, this is outside of your area of control, but partnering with somebody on the front end for that or ensuring it's accurate is important, because any of that revenue that's coming in for your services in radiology and you getting credit for that, all these processes are dependent upon it. So even if it's outside of your realm, you still, there's an impact to you operationally in terms of your budget, in terms of your revenue, and all those things that go along with it. So if I keep moving through the process, now let's talk about kind of documentation and coding and billing. So when I look at, people say, okay, if I'm going to go find, quote, find some money, right, from a revenue standpoint, I would say there's probably not a ton of places where there's easy money to find. As interventional coding has gotten more bundled, I would say a little bit simplified in some ways, there's not a lot of times places or people are missing big pieces. On the diagnostic side, it's typically lack of medical necessity that's more of an issue of anything else versus missing procedures. On the interventional side, sometimes there is a little bit. So what I want to do is just hit some of the high points of potential. And again, the word very much is potential opportunity within an organization. There clearly must be documentation, medical necessity, all those things are going to come into play. But if these things are being done and appropriately documented, we do want to make sure that we don't miss them. And this is an area where, especially even on the hospital side, we might see that organizations miss some of these particular services. Now, E&M is physician only, pretty much with that, but I do want to spend a few minutes talking about it, because with the changes that have occurred with the E&M evaluation and management guidelines, it's really opened up a lot of flexibility for being able to bill for services that historically our interventional radiologists could not. And so a lot of groups are really having conversations, and not just groups, academic settings, all different types of settings, of how do we make sure that the systems are set up for them and that they are appropriately billing for services that they're doing, where prior to this year it really wasn't feasible just because of the amount of documentation required. So let's first spend a few minutes talking about interventional procedures, and then we'll get into the actual E&M piece of that as well. So we think about our interventional procedures, and there's a lot of components with it, and a lot of it tends to get very bundled in, but there are some areas where it's not bundled in. So every interventional procedure, when I think around the vascular piece specifically, not all of the codes, include catheterization. So there may be situations where we are allowed to build cath codes, or even multiple cath codes, depending on what's being done. Diagnostic angios, which I'll go over the guidelines, and then also some things around image guidance. And there's situations where we can add on ultrasound guidance for access, or even 3D for certain procedures, and then even like our cone beam CTs and things like that. So for cath placement as a starting point, a lot of them include catheterization by definition, like any of our lower extremity studies or procedures, not studies, but procedures. So, angioplasty, stent placement, etc. Anything that the code is written exactly for that area, like carotid stent placement, they include the catheterization code. But if it's not, it actually does not include the code, and we are allowed to bill it separately. So, and that's physician and facility side. So embolization is a great example. Think about Y90 cases. Think about embolization in other areas as well. All those catheterizations that are done, you are allowed to bill for. So making sure we understand what exactly the physician did and what the documentation is important. For those of you on the facility side, there's not one way that charges get captured. It could be captured in the department where, you're setting up, and the technologist, as the case is concluded, may be selecting exactly what was done. That flows through the system, and then somebody kind of, in essence, kind of picks it up and does the diagnosis code. Other places, if you think about with an Epic, it'll trigger a charge to kind of hold the charge in the system, and then it goes to coding, and coding actually assigns all of the CPT codes and the diagnosis codes. Regardless, we want to make sure that those things aren't being missed. And a lot of organizations, again, there's a lot of very talented, qualified people doing the coding function, but some of them maybe don't know interventional as well as others. And so making sure that you're comfortable that the codes they're selecting ultimately are accurate and reflect all the services that are performed for your organization. So one way you can check that is looking at a listing of all the billed codes that you have for a month, a quarter, a year, and see how that compares with what you've actually done. And if you see you've got some gaps in there, that's an area to go look at to see, are you missing any potential revenue for that? So I mentioned diagnostic angios. So diagnostic angiograms, from an overall standpoint in the CPT manual, as well as in some edits that exist, is that diagnostic angios are considered part of a transcatheter therapy unless we meet certain criteria to bill for it separately. The reason they put that in place is they did not want to pay and do not want to pay for a diagnostic angio done at the time of the encounter just to verify that a procedure can be done, right? So they want to really show that it's truly separate and distinct for that. So there's very few procedures that actually, by definition, include a diagnostic angio. It's more about the edits that were put in place for that piece of it. So if we look at the guidelines, and this comes straight out of the CPT book with that, the guidelines say that we are allowed to code for both, not if they do both, but actually code for both. If one, the patient's never had a prior catheter-based study prior to the exam, or they have had a prior-based study, but the patient's condition has changed. Maybe they just treated a blood clot. Maybe the patient's had to come back into the suite for some reason. There's an adequate visualization of the anatomy, or there's a clinical change during the procedure. So there's not a time period for this. So it's not, well, what if they had one yesterday or 2 weeks ago? It's all about these specific conditions with that. So if we're billing both a diagnostic angio and a transcatheter therapy, then we're going to need to put a modifier on there. Now, there is one other exception to let you know about, in that Medicare includes CTA to be considered an angiogram. So when a patient comes to the suite, if they've had a prior catheter-based study or a CTA to diagnose that condition that is now being treated, we would have to show in the report what criteria was met in order to bill for that separately. So there's a lot of times where it absolutely is appropriate to bill for that separate diagnostic angio. On the hospital side, those diagnostic angios are a status N, which means they're not separately paid, but that's for Medicare, and other payers may provide separate payment, especially if they're paying based on a percentage of charges, and some contracts still do. So regardless of who the payer is, you would want to capture those charges and let the revenue cycle process really kind of play itself out from that standpoint. Other areas in interventional, that additional selective study, 75774, additional selective study, we do get to use that, not as much head and neck anymore because of how they redid the codes. You could do it for your costocervical, thyrocervical. I know we don't do a lot of those, but I would expect to see this more in our Y90 cases, things branching off the aorta where they're doing additional selective studies. So especially once we get out into the celiac and all those different areas, we want to make sure we capture those, again, on the professional and the technical side for those additional selective studies. Also, when we think about our interventional procedures around 3D, so 3D gets used in a lot of different ways. We may see it for head and neck studies. We may even see it for hepatics, other areas with aneurysms, AV malformations, etc. With that, we can bill it, but we need to make sure we meet the definition. So the definition for this code does require that the physician be driving what exactly is going to be reconstructed, what images are going to be archived, and monitoring that particular process with it. So if we do bill 3D, we're going to be billing it once per procedure only with that. So regardless of how much time it takes, all the different components with it, we're going to get it once per procedure for it. And we don't get to bill it if it's something that the technologist is doing on a separate workstation. This is only for the scenario where our physician is actually directing it, doing that acquisition piece and driving that process. So we could have definitely 3D in some of our IR cases. And then the next question then becomes, well, what about CT? With that, it could be a hybrid angio CT or it could be a cone beam CT. For either one of those, we are allowed to code separately for a CT. With that, it's coded as a limited exam, a 76380, and regardless of how much it's done, it's 1 unit for that particular piece with it. So again, we want to make sure that they're actually using that the CT images, and this is important. So it's actually taking diagnostic images in order to be able to perform the service. With it, you can code both 3D and CT if documentation is there. But this is not just CT guidance to do a procedure itself. That would be our regular CT guidance code. So we have one for ablation, we have one for needle localization with it. But in those situations where you're doing the cone beam or the hybrid, again, Some places do it with Y90s, some places do it with other procedures. With it, it's not, we don't just go out and bill it. We want to make sure we have the documentation to go with it. But if you're doing it and you're not billing for it, you want to make sure you're not missing revenue in that particular area. So I mentioned ultrasound guidance 76937. This code was originally created around our central venous catheter procedures. And so, you know, that's never been a question, but they've expanded the ability to use that. So if we have providers who are using this for vascular access and they're meeting all of the criteria for the code, we can bill for this particular study. I do notice, and some of you may not only deal with interventional radiologists, you may deal with cardiology, you may deal with vascular surgery, and you may find that they actually use this code more than interventional radiology does from that standpoint. But just, you know, again, if it's being done, if the criteria is met, you can bill for it. We do want to make sure that, again, the documentation around there, where they've kind of relaxed a little bit what the documentation requirements are. There is some authoritative guidance around what needs to be said about the vessel being patent, you know, narrowed, etc., related to that. So it's not just for a handheld to identify where to puncture, but it actually is going to have commentary around the vessel. We know that permanent images have to be taken. All of that comes into play. So that's just a high-level place to go look at IR. If I were going to say, are you sure that you're capturing everything for IR? Clearly, there may be other things that you're doing around specific procedures that you want to validate and make sure that you're not missing anything. But I would at least look at those just to identify that. Now, I want to spend a few minutes just talking about E&M, just because this is an area that's a real hot topic for interventional practices to really say, okay, now again, now that things are a little bit easier, more appropriate, they could say, to capture those charges, are there situations where we're seeing patients that we should be billing for that? If we're rounding on the patient the next day, or we're doing clinic visits, or we're doing, there's a lot of different scenarios, are we appropriately billing for those? And then also, are we using extenders appropriately? So I will briefly mention extenders as well, not, you know, and where they potentially come into play for it. So the question sometimes comes up is, you know, can radiologists report visits with a patient? And the short answer is yes, absolutely. The real question is looking at, you know, the when, how, when, what, and how, right? When can they bill it? When can they bill an E&M service? What type of service are they going to be billing? And how are we going to capture the documentation for that? So we have a RIS system, right? Our radiology information system, whether you're using Radiant, whether you're using Meditech, all those different systems that are out there, you know, those are typically set up from a workflow standpoint to handle our procedures, right? Or interpretations of studies. When our radiologist is interacting with a patient, it usually becomes, if you could put it in that EMR, great, but a lot of times you're putting it in Epic or you're putting it in Cerner. So you have that challenge of getting that information from Epic into the RIS system so it can follow that billing process. Ultimately, you want it in an interface. It's possible. That's an example where, you know, that may be the end result of what you want to do, but it may take the programmers, you know, 6, 9, 12 months to get it done. So what do I do in the meantime? Well, regardless of the number of physicians you have, E&M is probably not going to be so crazy insane volume that you can't create a workaround. What have some people done? They have created a workaround to set up an accession number for those E&M visits, and someone will literally go in, copy and paste out of Epic into the RIS system so that it will follow the process flow as it relates to it. Again, I'm not advocating any workaround. I'm just sharing what others have done to make sure that we get that physician's documentation and to put it into the system. So we think about the role of our radiologist, right? So the role of the radiologist is to do interpretation, share results, but sometimes the role of our radiologist is to actually evaluate that patient, develop a treatment plan, and do services for that. So the first question I always ask is, let's talk about your scope of practice. Let's talk about what the group really does. So when we talk about E&M, it really is about interventional radiology, not diagnostic. Now we could spend time talking about breast imaging and a breast center and where your doctors own the patients. There's the potential for that, but that's I would say almost a whole different conversation. Let's talk about this through the lens of interventional radiology. And so then we go back to, well, what is your scope of service? So when somebody that's an ordering provider wants a radiology service, interventional service, I should say, how do they order that? That's a very, very key question. Is it put into the system as a consult for interventional services, or are they specifically asked to do an exam? Now, it's probably going to be a little bit of a combination. I mean, if they just need a PICC line or central venous catheter, they're not going to say, I need a consultation for a PICC line. They're going to just say, this is what I need. Okay, that's a percentage. But for the rest of it, are they telling our docs to do Y90, or are they consulting with our docs to do Y90? Are they telling them to do an embolization, or telling them to do a stent placement, or are they asking for a consultation? Flipping that narrative a little bit and getting the ordering providers to recognize that they need to be consulting with our providers for that, because that is generally what most practices are doing, makes a big change, because now it changes that and it really lines up for that consultation component to happen. So even back to that ordering piece becomes really critical of the next steps of how that physician is going to be specifically treated as it relates to that. So let's talk about what a visit is. So for a visit, for them to bill an E&M visit, there has to be a face-to-face component. And yes, there's some telemedicine codes, that type of thing out there, but let's just talk about just overall E&M. There has to be face-to-face with the patient. This is not just talking about the patient, those types of things with it. So we look at E&M, again, it's doing evaluation, treatments, all those types of things. All the E&M codes that exist can technically be used by any provider. So there are some intra-professional E&Ms, but you have some specific coding guidelines that go with that and billing guidelines with it. But let's just focus on just inpatient, outpatient, seeing the patients, take care of them from that standpoint. So there's that piece of it. If our physician, if all they're doing is just to determine whether or not they can do the procedure, right? So we go check on the patient, you know, how is Melody today based on Melody's other comorbidities and, you know, her current medical condition, can I do this procedure? That's not separately billable, right? For us to do something separate, there must be something separately identifiable from just validating that a particular exam can be performed. The work involved to make sure that an exam can be performed is actually already built into the relative value units of the procedure itself. So where are they going to document this? They could document the E&M in a procedure note, not ideal, with it. They could do a separate paragraph, you know, with that particular piece of it, but really ideally, E&M documentation stands alone. That makes it crystal clear. It's separate and distinct with that. Again, you could put it with a procedure note, but we really do recommend separate for that. Now, as an overall comment, I've heard people say, well, you know, this other practice, they bill an E&M for every procedure they do. I feel extremely comfortable telling you that's not appropriate. You're not going to be billing an E&M with every single procedure that's being performed on the patient. So again, you're going to have to look at what exactly they're doing in that particular case. So we can't ignore global surgery. For those of you on the hospital, you don't have to worry about global surgery with that. This is a physician-only concept, and the reason this exists is it goes to the value of the codes and what they get paid for them and what's included in there. So if something has a 90-day global period, we don't have many of those in IR. With it, that means everything associated with that treatment and follow-ups for 90 days is all included. They don't get any additional payment. Most of what we see is going to fall into that 000 category. It's called a minor procedure. And so they look at the definition of that. It says the decision to perform minor surgery is included in payment of the minor surgery and not separately reportable. If there is a significant and separately identifiable E&M service with it, you are allowed to do it. So basically everything that's included in that day is not separately billable, but if we saw the patient the next day, so the majority of the procedures that we see, embolizations, vascular procedures, all those kind of things fall into that 000, so same day. Now, if they truly did a separate consult, we could bill that, but anything around that procedure, follow-ups on that same day would be included. It would be anything the additional day that we could do that. So if it's the same day, we have a modifier 25 that we need to put on there. We're communicating. I promise you it wasn't part of the procedure. I really did something above and beyond. I have documentation to prove it. Please pay me, right? So that's the piece that goes along with that. So medical necessity is always key as it relates to these pieces of it. Medical necessity, medical necessity, medical necessity. I can't say that enough because that is the overriding factor. Just because you can do something doesn't mean you should from a billing standpoint. Do I meet the definition of medical necessity? So that's always the litmus test. So if that's ever a conversation within your organization, that would always be the question about, okay, I know we can, but why should we do that? So office visits, outpatient, and we'll see the same for inpatient, are determined by medical decision-making or time. and it's not all or nothing for every patient. It's patient specific. So it may be for a patient, medical decision making is higher. It may be that time is higher. So you don't make a decision as an organization that it's always one or the other. Again, it's patient specific. I would say that for a lot of IR groups, medical decision making tends to be the driving factor, because once you look at the time requirements, you'll say, oh, I know they're not spending that amount of time. It's really going to be about that particular piece for it. So if you look at the levels of medical decision making, we're not going to go through how to determine levels of medical decision making, but you can see moderate and high is what gets us higher levels, level 4s and level 5s. With that, think about going to a doctor's office visit. You've all been to your family practitioner, internal medicine. These are the same levels they have, like when you come out of the office, right, and they've checked it off on a sheet, or nowadays we're electronic, it's not on a piece of paper. But when you look at that, most of what our physicians are going to see are going to fall into that moderate or high with it. But again, they've got to have documentation and medical necessity for it. Time itself has to be exact, and they have to add it up. So, when we get into time, it doesn't matter what they're doing it for. We can use that now as a selection for that particular piece of it. And again, it's the minimum time. It can't be estimates. It can't be I spent approximately 20 minutes, approximately 30 minutes. We have to track exact time. And it's everything related to time for that complete date of service. And that includes face-to-face time. It includes things that they do related to the patient, and I'll show you a list of it, but it does not count ancillary staff time, so it does not count a nurse or a medical assistant or anything like that with it. The only providers that it counts is if we have a physician and what they call an other qualified health professional, which is somebody who could bill under his or her own name, which would be a nurse practitioner or a PA. So we can add their time together. We can't duplicate, we can't double dip with that. But if we have it where they're doing that together, we can add their time together with it, but we can't double count it related to that. So those do get added together. There's a whole list of the things that can come into play around the activities that with it. So it doesn't have to be just this list, but this just gives you an idea of the different types of things: reviewing charts, talking to other physicians, getting expanded history, reviewing data. All those things can get added up together from a time standpoint. So new patients on the outpatient, this kind of gives you an idea of typical time of what goes into play with that. So if I'm between, this particular piece and what the requirement is, anything up to 30 minutes is going to be a level 2, and then you can kind of see how that goes out from there. And then our established patient visits, the first one, the time component was removed because typically physicians don't bill level 1, and then you've got your follow-ups from that. So you can see as you get to those higher levels, we're talking 40 minutes, 50 minutes above, and that's where you may see medical decision-making really being that driver for it. So as you look at documentation, reason for the encounter, why did we see the patient, any pertinent history or exam, not a requirement, but anything pertinent, and then what they specifically address for it. And then just to mention hospital, so for 2023, they made changes for it to implement the same kind of guidelines for inpatient that they had already implemented for outpatient, which is really where the opportunities have now come in for our IR physicians with it. They combined inpatient and observation care because individual payers now dictate whether something is observation or inpatient, which creates a whole lot of challenges for the hospital side. The physician side, they kind of took them out of the game on it. So it doesn't really matter if they're at the hospital and they're admitted, whether it's observation or inpatient, we're going to count that as the visit, and you can bill for it. And then subsequent, same thing with observation care, etc. So it's now allowed for time and medical decision making as well. There's only 3 levels of care for inpatient versus the 5 levels on the outpatient side. And you can see what the time requirements are. So for a new patient, or we don't really call it new patient, initial patient visit, that's where you get into the 40-minute, 55, 75, subsequent 25, 35, 50. And again, you start looking at those times and you go, that's a lot of time for the radiologist to spend with the patient on the floor for that piece of it. Are they really doing it? Maybe they are, or again, we're back to medical decision making. So that's why we were going to see a lot of them following into more moderate and high for that particular piece. There's a little grid for you that you have in the handout that kind of shows you by the different types of codes that you'll see on the inpatient side, what the medical decision-making requirements are for those particular areas. Again, there's a lot that goes behind the scenes around the documentation for medical decision-making, and if you need any of that, I'm happy to share it with you. Just time doesn't allow to really go through all the details on that piece of it. So you'll notice the documentation requirements on the inpatient is really the same as outpatient from that standpoint. Again, reason for the encounter, pertinent history, all those types of things come into play. So hand in hand with that, you know, non-physician practitioners, there's a lot of different things that non-physician practitioners can do in terms of revenue, because that's our focus today with it. How do we use our extenders from that piece of it? So there's a lot of different ways you can use extenders. E&M is one of them. And again, there's a lot of different criteria that are going to come into play. If you're using extenders, you want to make sure that you're billing for those appropriately. And if I look at my potentially billable services, it's going to be based on state law. It's also going to be based on hospital bylaws. And so it really kind of breaks down, can they do admissions? Well, it depends whether or not they're allowed to, you know, admit from that. So again, it's going to depend on your hospital privileges for that. Can they do consultations on new patients? Can they do follow-up visits? Can they even do interventional procedures? There's opportunity potentially to expand some revenue based on that piece. So you have to look at your state law and your other components for them. There's also some other kind of guidance around, if you're doing those services, who does it get billed under when you're doing those particular pieces. Now I mentioned, you know, what if a provider sees a patient with a qualified health professional, an NP or PA. In the hospital setting, there is no incident to. You're going to bill it under one physician name, and you're going to bill it under the provider who did the substantive portion of the visit, which is a fancy way of saying how they decide which one you're going to bill it under. And there have been some processes where they're undergoing change, and it was supposed to be starting January 1 of 2024, whoever spent the most time with the patient or about the patient would be who it was billed by. And in the proposed rule, which just came out about 2 to 3 weeks ago, I guess probably like 3 to 4 weeks ago at this point, they've actually proposed to delay that by even another year. So it'd be January 1, 2015. So watch that when the final rule comes out in terms of what that looks like. So last year in the final rule, CMS had put in there their final policies around what defines substantive. And so right now in 2023, it's either who spent more time or who did the bulk of the medical decision making. So typically that leans towards the radiologist. And it was supposed to change 2024, but again, that may be expanded out one more year. So we're definitely going to watch that. If we are doing it from this piece of it, we do have to put a modifier on there. They want to track it. They being CMS wants to track how often these shared visits are actually performed with that. So documentation, mentioning both providers, how much total time each one of them spent, and them documenting that becomes a key piece. So I'll leave you with, for that area, kind of a decision tree that kind of walks you through how do you decide who something gets billed under, whether it is the extender, the NP, or the PA, or it's the radiologists themselves kind of driving that particular process. So again, definitely an opportunity potentially with some of those extenders as well. So let's talk about, I mentioned physician engagement as well. So we just talked about, you know, E&M and some of the procedures and getting our physicians involved. We can do that. Again, I'm a big advocate for doing it, but we need to be specific. What are the specific issues? If you've got, let's say that you've got 2 or 3 physicians that everybody else documents great, but if these 2 to 3 physicians would just do a little bit better documentation, we really could make more money, because it's going to allow us to bill a higher level, an appropriate high level for that. Getting that physician advocate to help you is definitely something with it, and collaborating with them to figure out how to go address the specific physician. So again, getting them on your side to help makes a big difference. So we've come through, we talked about front end, we've talked about the middle. So now somebody in billing got it out the door, right? Now we're getting denials, and all of a sudden we're hearing about we're not getting paid for things, but yet we're doing all this great work and we're doing all the things that we need to. So let's talk about denials. Do you know what the denials are for your area? I would argue you should. Whatever your role is, you want to know what your denials are, and they should be able to give it to you. They can slice and dice the data to give you denials. And do it in such a way that it's actually can read as plain English, not just a bunch of reason codes and everything else. So you should be able to answer the question, what's causing your denials, right? You want to know the answer to that. It's your revenue. You're looking at it. So is it lack of authorization? Is it bad demographic data? Is my problem all on the front end? What's going on? And everybody's answer is different. You can't just walk in to one location and say, well, this must be all your problems. The first thing I always want to do is look at denials. Let's see what the problems are, because if I look at denials, I can go tell you where a lot of your issues are from a process standpoint. Are they controllable or preventable? That's a big question, because some denials are, some denials aren't. If a patient gives you bad information, is it preventable? Yeah, but only as much as you can make the patient give you good information. But could we have done something differently to prevent that denial? And I'll show you what I mean. And can we appeal them? Can we go back and ask the payer to, can we appeal and say, please do pay us, here's some additional information for it? And how do we fix the problem? We can't just say that this is okay. So if I look at authorizations denials, there's really three main reasons that I'm going to see pop up as reasons for my authorization. One is we didn't even get one. That's a problem, right? If we know this patient required an authorization to get that CT or that MR or that PET scan, whatever it is, and I didn't get it, why didn't we get it? I mean, if it was an emergency, then not that we want to tell warding providers to send their patients to the ER. We don't want them to do that. But, if it's scheduled outpatient, what is it? Why did we do that? If we knew we didn't have the authorization? What if they authorized the incorrect exam? Happens all the time, right? They ordered one thing, maybe they changed the order, somebody got confused, they didn't authorize the right exam, so we got approval to do a CT abdomen, but we really didn't abdomen pelvis, so then we got denied, and we did that for free, which we don't want to do. Or, again, we did it without they either didn't have the authorization obtained, didn't even bother, or they're in the process of doing it, or it was denied, but we did it anyway. So you can see these different categories that things could definitely fall into. When I talk about appealable denials versus non-appealable or preventable denials, if we obtained the auth, but it was still denied, why? Now, there are times a payer will say, well, just because we gave you an authorization doesn't mean we're going to choose to pay you. I would still fight that. But if we did it and we have the auth and we put it on the claim, why did they deny it? Did they deny it saying it was lack of auth? That could be an error on the payer's part. It happens. Let's appeal those. Let's find out, why are they not paying us when they said they would? Preventable denials, back to I just kind of mentioned, we got the wrong exam authorized. We didn't get authorization. We deliberately did the exam when we knew the patient was denied, or the patient, was self-pay, whatever, because of that lack of auth. There's a lot of implications of all of these, but we need to be able to speak very concretely to definite numbers. We can't say, oh, they're terrible. They do this terrible all the time. Let's get very specific numbers. This is how we're going to go enact changes, right? So even as I said at the beginning, this is an area maybe outside of your control, but if you can show we're writing off $300,000 last month because they didn't have authorization for us, and I don't want to put the technologists in the position of having to police all of this. So you got to balance that. But if you see this money that you're losing because someone is not doing it, if somebody brought something to you with quality information and said, hey, these are the number of exams that you have a technologist doing incorrectly, and they've got quality data, are you going to ignore that? No, you're not going to ignore it, right? This is all about how do we approach it from a collaboration and teamwork standpoint, so you get to employ all of your wonderful skills of change management and teamwork to try to make those changes. So getting our physicians aware of what the denials are is important, because they don't know. I mean, we sometimes can assume that they have this information. I promise you they don't, unless someone puts it in front of them. Letting them know what the issues are, they can become very powerful advocates to help you and get their assistance for it. I mentioned appeals earlier. Things that the physicians can help with appeals would be things around medical necessity letters back to a payer. You definitely want to track when you're getting a lot of denials of a particular type, because we may need to get the physician to talk to the medical director of a payer. All of a sudden, I'm just going to make up something, but all of a sudden our vertebroplasties are getting denied in this particular payer, or kyphoplasties or bone ablations. There's all sorts of things that pop up. If we see this trend, that we need to go do something about it. We need to get with the payer to find out why they're not providing coverage, and let's see what we can do to change that payer's mind, because these could be expensive procedures, and it's not just we're just going to ask the patient to pay for it. That's not feasible. These patients may choose not to have the service, if there's not a way to have payment. And they can do what's called peer-to-peer, where physicians talk to physicians at the insurance company for them to explain why a particular study needs to be done. And last but not least, on the credentialing side, credentialing is important because think about telerad, think about these providers that you have interpreting studies outside of your state, outside of your jurisdiction. We've got to go through to make sure that any place that our radiologists are doing interpretations of studies, so we're talking diagnostic here, that they're appropriately credentialed with those payers. Ideally, we can set up a workflow where they only do interpretations of things that they're actually credentialed for. Some places workflows don't allow it, but ideally you do. And making sure that we're aligning that. So as we think about it with the physicians, if we're going to be doing teleradiology, that we understand exactly where those physicians are going to be seated when they're doing those interpretations, because it's a lot of work on the back end to make sure that those are going to get billed correctly. So what may seem like just a small operational thing can potentially become a very big issue for that piece of it. So making sure they understand how much time is needed to work through that credentialing process so that we can avoid unnecessary denials and lost revenue from that standpoint as well. So I have done a whirlwind tour of all the different places where if you're going to go look for potentially for revenue, you might want to go do that. And I would bet everybody's list turns out a little bit differently. So got about 5 minutes. I'm going to stop and turn it over for questions to see how many questions we can knock through.
Okay, thank you so much, Melody. We've got a few come in. The first one is, do you have any strategies to get the radiologist's attention regarding denials?
Money talks, right? So I think the biggest thing I would say is, especially when you drill it down to the individual physician level, if you look at what are denials that maybe they could help and control. They can't control everything, but maybe there's things around medical necessity where there could have been improvements in documentation. Let's say, and even beyond denials, I would say if you're having to code limited studies, but if the documentation had been improved, you could have coded as complete, or you missed the opportunity to code diagnostic angios because their documentation wasn't there. You can't just kick all those back to the physicians to modify their reports. It has to be would change the clinical outcome for the patient. But if you track all those and you're able to quantify and say it's X amount of dollars to the practice, and that's visible, that can help really make a difference. Again, it's all about how we present it. I'm making it sound a little bit harsher than I mean to. We always do it with grace and finesse, right? But presenting it in a way that's just focused on the facts can really make a difference for that.
Perfect. So here's another question. Where do you typically see the biggest opportunities to bill EM services?
I would say inpatient side, rounding on patients who are in the hospital more than a day, and checking on those patients. So depending on the scope of service that you have or scope of practice that you have within your organization, looking at the types of procedures that are done, I would definitely talk to those IR docs who are doing more complicated procedures and find out what they're doing. Or again, if it's an NP or PA and they're rounding, fine, as long as it's allowed, which it typically is, then they would be billing the E&M for that particular service.
Okay, that's great. We've got time for one more question here. How do organisations deal with getting EM visit notes to their billing company?
That's a good question, because for many places, if it's within the system, that's a little bit easier. Again, if you're part of academic or you're part of a closed system, as I would say, and everybody has access to Epic as well as the other, it's not an issue. But if you're using an outside billing company, ideally you can get it into the feed, as we call it, going to the billing company. You may have to go back to that manual system that I mentioned where you're cutting and pasting, where you set up an accession number, cut and paste it in the system so that it'll make its way through to the billing company side. The other thing that I've seen done is if the physicians themselves are responsible for capturing or assigning the E&M, you set up a different mechanism where they provide that information over either through a secure portal or some other way of the radiologist communicating, hey, these are all the visits I had this day and here's my levels of service. In that case, the billing company wouldn't be looking at the E&M notes. They were just, in their contract, would have it clear that we're just taking what you're giving us and billing us, and you're basically certifying to us that you have the documentation in the medical record. Okay. I think that's the last of our questions that we have. So I want to thank everybody for their time today and coming. I know there's some handouts piece of it.
Okay,
There
great.
you
Well,
are.
we've come.
Yeah, go ahead. I didn't know if your audio went
Yes,
out, so I was
thank
jumping in for you. All yours. Wrap it up for us.
yeah. Thank you so much. I appreciate it. Well, thank you so much, Melody, for your time today and for such a great and really informative presentation. As promised, the answer to today's trivia question is brown. So congratulations to our winner, Devin Dixon. A quick reminder, you can obtain your certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 ART Category A CE credit by HRA, and you'll be able computer once the survey is submitted. If you download the certificate directly from your computer, if you have any questions, you can reach us at webinar@mdpublishing.com. Please visit icewebinars.live for more details of all our upcoming ICE webinars and, of course, complimentary registration. Thank you again for your time today, and I hope you enjoy the rest of your day.